Okay, so I was trying to be brief in this one. Hypertension already had an update. So how we can tailor, we go to the management, how we can tailor our management for patient in front of us. Patient come to you, is not you're not treating the population, you're treating the patient in front of you. And this is why I try to, as a cardiologist, these patients normally come with the comorbidities, many things together, it's not one thing. So hypertension, you find it in almost every patient with acute coronary syndrome in this region, whether you like it or not, it's there. And of course, the intervention is maybe a treat and management, but that's not the goal. They try to prevent. And we already discussed this. It's very common. Almost half of the population in the world having blood pressure if you apply different definitions, but it's at least above the billion. And the problem is not only the management, is the control. We are very, very, very bad in that. Regardless, you look in American, European, in our region, the same. What happened? Jump. Okay, so again, this is already discussed quickly with you. And so what we try to do is try to lower that control aspect or increase it, have better control. In our regions, around 17%. Problem with the blood pressure you see in the case I presented to you is not happens in isolation, always something else, dyslipidemia, obesity, diabetes, especially in our region. So always the friend is there, okay? And the problem is this, when the control, again, this is maybe from European, but the same apply in our region. I think the new guidelines made our life very simple, okay? So there are a number in the context you don't treat, okay? And then a number you need to reevaluate, which is nicely stated today. And then there's a number in the context you have to treat. Lifestyle and medication, and these are all available with you, but how to apply them, that depends on how you are and how's your patient with you in terms of believing in you. One thing which is related to the symposium is the sympathetic overdrive. It's very common, especially if you are living in Dubai, for example, going in the morning with the traffic, and it's so really is stressful, and the people, nobody happy. People everyone's in a hurry, wants to reach there. So it's happening to the young age, middle age, everyone. So again, having that stress or sympathetic overdrive, of course, we've seen it ourselves, you've seen it. It's related to anything, starting from obesity to the diabetes, and then, of course, the outcome we've seen. All the guidelines nowadays, they talk about combination when it comes to management. Of course, you've done your job, you've evaluated the patient, you know this patient got hypertension, you come to the starting management, whether it's guidelines, the old one or the new one, start with the combination. And the combination, the new one, that tells you start with a lower dose, which is, again, is nice to start with lower dose, then you can go up. And nicely stated with the updated guidelines, start with low, then, it depends the patients, how we respond to that management, which you started, whether it's RASIs, whether it's CCB, whether it's beta block, whatever it is, depends on the context, the patient in front of you. So I don't think one size fits all, but you need to reassess your patient to decide which one to treat. But in general, your aim is to lower that blood pressure to the target which is mentioned in the guidelines. But again, that depends on ALARA. ALARA means as low as achievable. You don't want to harm the patient with what you do. You want the patient, again, take the medication. That's our major problem. Of course, and then when you come to the combination, should be synergistic. You choose the one which is very, very synergistic and always shared decision. So why we talk about the one which is today is about Concor AM. I don't know how many of you using Concor AM. Raise of hand. Okay. How you found it to start with? I mean, did you find it is a patient tells you, my side effects which I had maybe with the calcium antagonist is now better, or tells you the side effects I have with a beta blocker, you did this for me is better. I mean, I had the both feedback, you know. So having these two together is really synergistic. One aspect, like beta blocker, work on sympathetic, you know, and RASI, and the other one works on the vasculatures, and of course the outcome all there. So these are the benefits of this combination, and the complementary mechanism, that's what we want. This is the complementary effects of these two together, which is very, you know, based on pharmacodynamics, pharmacokinetics, and reaching the target. That's what you want. You want the patient get to the target as soon as achievable, you know, as possible. You can say it. It's 4 weeks. It's very nice. You know, 1 month, they come back to you, reevaluate them, patient and target. Patient tells you, look, I have no side effects which I used to have it in single or one of these two, alone. So that's very good. And to achieve that, I think that's our major problem, isn't it, with the medication nowadays in terms of hypertension. So reduction in blood pressure, achieving the target in the right time, I think that's what, and especially in the 24 hours, you look at the beta blockers, you know, its half-life is different than the calcium antagonist, which is having these two together really give you an ideal, you know, the cover of blood pressure, especially in non-dipping hypertension, as mentioned in this. So the benefit of fixed combination go beyond, you know, just blood pressure, is improve the outcomes, and that's the many of them there. It depends how you interpret the data, but even the one with the hemorrhagic stroke, they say it. So CV protection there, hemorrhagic stroke is there. Excellent adherence, that's what you want. I mean, medication for hypertension is not for a day or a week or a month or a year, it's for life, isn't it? I mean, you tell the patient, look, you need to change your lifestyle. Of course, there are some people who no need medication at certain time, but majority, they need it. So for them to adhere to the medication should be as simple and easy, and not harming them, not causing them side effects. So this is the adherence. Very, you know, very nice to have a medication as high as 86%. So excellent adherence, and this biggest study showed that, and that's great to hear, of course. So this is a study, of course, in details. I will not go through it because, you know, the whole idea to get you the message at this Concor AM. If you have not tried it, then try it, because it's fit almost all of your patients, you know, and these are based on the guidelines, which is already said that the flexible bisoprolol amlodipine, all these available. I'm sure if any hospital you work at nowadays, these combination available. I just a few days ago, I had this patient of mine, young patient. You know, the problem when you put a blood pressure machine, they don't wear it at night. If they wear it, you know, look at this, how many slept and take it off, I think a certain time. But anyway, young patient like this, I tried immediately on Concor AM, and you know, they felt much better. So these are the benefit of this fixed combination, and any comorbidities, it fits and has got really a good benefit outcome. So the harmony of control of using Concor AM is that you will get a good 24-hour control, which what we need. It's not just a daytime or nighttime, and then to get the target in a nice way, and patient to adhere to it. That's what you want at the end of the day. And to that, thank you very much. I hope that the message is reached you.